Hi, and welcome to Radonc Talks, a lecture series created for students and residents of radiation oncology. My name is Riemel Herker. I am a fourth-year radiation oncology resident at the University of Pittsburgh, and today I will be taking you through part 2 of our lecture on cord compression. If you haven't already, I would definitely check out part 1, where we discuss the anatomy, presentation, and workup of metastatic spinal cord compression, as well as the RADI scoring system that prognosticates ambulatory rates and overall survival in patients that present with spinal cord compression. If you do feel like you have a good handle on those things, though, it is now time for us to move on to the management of cord compression. And I really wanted to split this up into 2 lectures because I think it's really important that you come into the management section with a fresh mind and are prepared to kind of absorb all this information. Just because cord compression is one of the most common inpatient scenarios that we see as radiation oncologists. Obviously, it can affect our outpatients as well, but this is a very, very common consult. In my career so far, I have seen it numerous times while on call, and it's really important to know what to do when you're consulted for cord compression. We looked at this slide before, and we talked about that in metastatic cord compression, our goals with our treatments are really palliative, to provide pain control and to preserve neurologic function. Always, when we think about giving treatment, we're going to think about what our patient can tolerate based on their performance status, and also what makes sense based on the extent of their systemic disease. And this is really where that RADI's prognosis and risk stratification scoring system comes into play. And then we kind of get into the actual management. Now, I do want to take a second to point out that most of the time when patients present with cord compression, they already have an established diagnosis of cancer, and then they end up progressing and unfortunately end up with cord compression. However, there are situations when cord compression is kind of the presentation of their cancer, and they don't have any history of malignancy, and then they come in with either weakness, bowel bladder incontinence, and you see that there is something pressing on their cord. These situations can be really challenging because in an ideal situation, we will never deliver radiation unless we have a tissue diagnosis of cancer. And every clinical situation is unique. Whenever possible, I would say push for getting a tissue diagnosis, whether it involves, surgery to the spine or some kind of biopsy of a different site. I would say really push for trying to get that tissue confirmation of cancer. On the board exam, I think you always want to do that. And then in practice, this is a challenging scenario, and we really try to make sure that we know the patient has cancer, because there have been situations that I've seen where a patient comes in looking like they have metastatic cord compression, and it turns out to be infection or something like that. And obviously, radiation doesn't treat, bacterial infections. The good news for us as radiation oncologists is that radiation is never the first step in treating cord compression. It takes time to get patients simulated and get the radiation plan made. And these situations are emergencies, and so we don't have time, to do all that. We need some kind of temporizing measure. And that is where steroids come in. As you know, steroids are anti-inflammatory, and they really help to decrease any swelling caused by the cancer, and they help to kind of decrease the pressure on the spinal cord. There have been a few small randomized controlled trials to evaluate the efficacy of steroids in metastatic cord compression. One notable trial is the Sorensen trial, which was published in 1994, and they randomized 57 patients with metastatic cord compressions to either steroids plus radiation or palliative radiation alone. The dose of steroids that they used was actually really high. They used 96 milligrams of dexamethasone given as an IV bolus, followed by 96 milligrams of oral dexamethasone for 3 days, followed by a 10-day taper. And so they found that the patients that received steroids plus radiation had significantly higher ambulatory rates at 3 and 6 months versus patients that received radiation alone. So at 6 months, the ambulatory rates were almost 60% versus 30% with radiation alone. So as you can see, steroids definitely are helpful. And the mechanism is really decreasing the inflammation around the compression and helping to take some of the pressure off the cord. If you raised your eyebrows a little at that very high steroid dose, you're not alone. There were some additional trials coming out around the same time that looked at the same high dose of steroids similar to what we saw in the Sorensen trial versus a lower dose, more conventional, like what we see given today. And they actually found out that when they compared high dose to low dose steroids, the high dose steroids didn't actually make a difference in terms of the patient's outcome. So no difference in pain reduction, ambulation, or bladder function versus the conventional dose group. The patients that received high-dose steroids, as in the Sorensen trial, actually had some severe side effects though, including severe GI bleeds, one of them resulting in death, as well as GI perforation. They had additional, less severe side effects as well, including pneumonia, wound infection, persistent hyperglycemia. And so these studies tell us that, a lower dose of steroids is equally as effective, and steroids are not without, side effects. So as helpful as they are, we don't want to be using dangerously high doses. And so the typical regimen that you will see used in the setting of metastatic cord compression is a loading dose of 10 milligrams IV dexamethasone, followed by a maintenance dose. My go-to is usually 4 milligrams every 6 hours. We keep them on this dose for about 24 to 48 hours, and then if they have improvement, we can consider switching to oral steroids. After the definitive intervention is done, whether it's radiation or a combination of surgery and radiation, we will start to gradually taper. We decrease the dose every 4 days on average. It just depends what they've been on. But we start to kind of gradually taper the steroids, and our goal is to come completely off. Some patients won't tolerate being completely off steroids, and in these cases, we might need to restart them on something low dose, like 1 or 2 milligrams of dexamethasone daily, something that maintains their stability and something that doesn't have them, feeling worse. The other thing never to forget with steroids is GI prophylaxis. You always want to start a PPI or an H2 blocker because we know that steroids can have severe side effects in the GI tract, even causing perforation. So you always want to, when you get consulted on cord compression, one of your first thoughts should be start steroids and PPI. Once we've started the steroids, we can feel better that at least we have initiated a temporizing measure. However, we now need to think about the definitive management. And there's really two options that come to mind when we think of definitive management for cord compression. And these are radiation versus surgery. So, radiation is well tolerated. Its pros include that it has minimal morbidity and mortality associated with it. It can be very effective for radiosensitive tumors, and we can repeat it if needed. The downside of radiation, however, is that it does not stabilize the spine, and it can also have several days to actually have an effect and make patients feel better. How about neurosurgery? The pros of this are that it allows us to get a tissue diagnosis, and that can be key if this is a patient's first presentation and we don't have an established tissue diagnosis, or if they have a remote history of cancer and they're coming, years after with this new symptom. Sometimes it is critical for us to get the tissue diagnosis. So that is a definite huge pro of surgery. Surgery also allows for immediate cord decompression, and it can mechanically stabilize the spine and correct bony deformities. However, the downside of surgery, of course, is that there is a lot of morbidity and mortality associated with surgery, and this can pose a much higher risk in elderly, debilitated, and systemically ill patients. There are a few different types of surgery that the neurosurgeons can offer to patients. So one procedure that's very common is what is known as spinal decompression. And in spinal decompression, kind of the immediate tumor that's circumferentially compressing the spinal cord is removed. Hence decompression, the tumor is removed to relieve the pressure on the spinal cord. This is usually done through an anterior approach. Depending on how much tumor there is, a lot of times surgeons are not able to completely eradicate the tumor in that area. They're just able to remove what was pressing on the spinal cord. So it's really important to read the operative note, talk to the surgeon, and kind of understand exactly what happened in the OR. When they do perform the decompression, oftentimes the spinal cord is not stable, and so they need to reconstruct parts of the spine. Something that's a little bit more involved is what is known as a laminectomy. A laminectomy involves removal of the posterior arch of the vertebral body. So the lamina, which connects the spinous process to the transverse process, is removed. And this might be necessary if there is anterior extension of a posterior tumor. And, a laminectomy may destabilize the spine because we're literally removing a piece of the bone that's in the vertebra. Most advanced is probably what is known as a corpectomy, where we're removing the entire vertebral body, either via thoracotomy or a retroperitoneal approach. A corpectomy might delay radiation for 6 weeks because we have to allow for fusion. Obviously that this is a very intense invasive surgery. And so candidates for this surgery are people that have a really good life expectancy and a good performance status to begin with. If a patient has many different sites of metastases, they don't have a very good functional status, we probably wouldn't subject them to this intensive a procedure. A very early study that was published in 1980, kind of representative of many of the studies coming out around that time, randomized patients to radiation alone to the spine versus a decompressive laminectomy plus palliative radiation. Again, all these patients received steroids. And they found that the patients that received decompressive laminectomy actually didn't benefit, and there was no significant difference between the two arms in terms of pain relief, improved ambulation, or improved sphincter function. And, there were several other studies that were published around this time period with similar results. And so in this era, kind of like 1980s, radiation alone was really the modality of choice because we had evidence that adding a decompressive laminectomy really did not benefit these patients. The Patchell study, and Patchell is a very important name for you to know, not only in the context of spine radiation, but also brain. But anyway, this Patchell study that came out in 2005 kind of changed that treatment paradigm of radiation alone for spinal cord compression. In this study, they took 101 patients with metastatic spinal cord compression who had less than 48-hour history of paraplegia, expected survival of at least 3 months, and they randomized them to receive either decompressive surgery plus radiation, 30 gray and 10 fractions, or 30 gray and 10 fractions of radiation alone. And in this study, they actually excluded highly radiosensitive histologies, so they did not include patients with things like lymphoma, multiple myeloma, germ cell tumor. And also, their surgical approach was a little bit different. So they were just performing decompressive surgery, and the approach was kind of tailored to the location of the tumor within the patient. So in the prior study, everyone got a laminectomy. Here, they were only doing laminectomies for posteriorly located tumors and different approaches kind of depending on the location of the tumor itself. The results showed a clear benefit to the addition of decompressive surgery plus radiation. When they looked at ambulatory rates across all patients, the group that had decompressive surgery had ambulatory rates of 84% versus 57% with radiation alone, and that was statistically significant. There was a clear benefit to the addition of decompressive surgery in patients that were ambulatory at entry, as well as in patients that were non-ambulatory at entry. And surgery didn't just improve ambulation, it also significantly improved incontinence as well as overall survival. And it was a significant factor associated with longer ambulatory times on multivariate analysis, in addition to the pre-treatment functional status as well as having a breast primary. So clearly there is a benefit to decompressive surgery plus radiation. And so based on this study, without getting too much into the minutia, such as the criticisms and things like that, they are listed here on the slide. Based on this study, though, we realized that in patients that have a good enough functional status who present with a short duration of paraplegia, in this study they did less than 48 hours, and also in patients that do not have highly sensitive histologies and probably just one site of severe spinal cord compression, adding direct decompressive surgery prior to radiation allows for a higher rate of ambulation for longer periods of time. It also improves rates and duration of incontinence, it adds a small survival benefit, and reduces the needs for opiates and steroids, and so it really should be considered as the standard of care. So now that we've established kind of when to pursue decompressive surgery, let's talk a little bit about what exactly to do in terms of radiation. And the next few trials that I want to go through kind of highlight different radiation fractionation schedules and how to go about deciding which one to use. So once again, the name Rades pops up a lot. Rades did a lot of research in this area. And in this particular study, Rades performed a retrospective analysis comparing outcomes in patients that received long course versus short course palliative radiation to the spine. So long course treatment was 30 gray in 10 fractions or longer courses of 15 to 20 fractions. Now in the modern era, we typically won't provide anything greater than 30 gray in 10 fractions in the palliative setting. So just think of it as 30 gray in 10 fractions. Short course radiation included 8 gray in 1 fraction or 20 gray in 5 fractions. And these are also very commonly used today. So when they looked at the outcomes, they found that the patients who received long course radiation had better local control at 2 years. So long course radiation provided more longevity of control, which makes sense. However, in terms of symptom management, there was no difference between short and long course in terms of motor function or ambulatory rates. So the takeaway here from this retrospective study is that long course provides more durable control, but short course still provides equivalent symptom control. And so the recommendation from this study is really to kind of tailor your radiation course based on the patient. If the patient looks well and you expect them to live for a long time, try to give them 30 gray in 10 fractions to get more durable control. However, if they have kind of a poor functional status and we don't expect them to live very long, 8 gray in 1 fraction or even 20 gray in 5 fractions will still provide equivalent symptom control. Based on the results of that retrospective study, Rades then came out in 2011 with a prospective non-randomized study kind of comparing the exact same things. So they compared short course radiation, 8 gray in 1 or 20 gray in 5, to long course radiation, 30 gray in 10 or more fractions, and drew the exact same conclusions. So the local control was better with long course radiation, but there was no difference in overall survival or motor function improvement, kind of corroborating the results of the prior study. So far, though, none of these trials have represented level 1 evidence. In 2016, Rades came out with the SCORE 2 trial, which was now a phase 3 prospective randomized trial, so level 1 evidence, and it was a non-inferiority trial in patients with kind of poor to intermediate life expectancy with cord compression, Rades score of 35 points or less. And these patients were randomized to receive 20 gray in 5 fractions, which remember was short course radiation, versus long course of 30 gray in 10 fractions. And the primary endpoint was overall motor response rate at 1 month. The conclusions from this trial were that short course radiation was not significantly inferior to long course radiation. So it was a non-inferiority trial and the non-inferiority criteria were met. So short course radiation is non-inferior in terms of overall motor response rate. In 2019, they then published an update which actually showed short course radiation is non-inferior in terms of pain and distress relief as well. So already from these prior trials, we knew that short course radiation provides kind of equivalent symptom control and motor response, but now with the SCORE 2 trial, we actually have level 1 evidence that 20 and 5 is non-inferior to 30 and 10 in terms of these symptomatic endpoints. The next step was then to compare 8 gray times 1 to 20 gray in 5 fractions in the SCORAD randomized controlled trial, which Rady's published in 2019. And so, just like in the last trial, they randomized patients now to these 2 short course regimens, 8 gray times 1 or 20 gray in 5. And they found that there was no difference in terms of time to loss of ambulation, time to recovery of ambulation, or overall survival. However, it's important to note that the non-inferiority criteria were not met for 8 gray times 1. So, when you look at the curve in terms of patients alive, when you look at the time to loss of ambulation and time to recovery, things seem pretty equivalent between the two groups. But technically, in the trial, the non-inferiority criteria were not met for 8 gray times 1. So what does that mean for us? I think the takeaway is that single fraction radiation should still be considered in patients that have metastatic spinal cord compression and very poor survival. But just know that it was not shown to be non-inferior. And so if you think that a patient can tolerate 5 fractions, and if you think they're going to live long enough to receive a benefit from that, then go ahead and choose the fractionation. I'd like to just take a pause here and kind of summarize what we know now based on the evidence that we have reviewed so far. So we know that the first step when you see cord compression, even if it's just on a CT scan, is to immediately start steroids. We give IV dexamethasone 10 milligrams loading, and then we give 4 to 6 milligrams every 6 to 8 hours. We also want to obtain a full MRI of the spine with and without contrast. Now, if you see cord compression on a CT scan, don't wait to start the steroids. Start the steroids and then get the MRI, which can take a little bit of time for the patient to actually get. Once we have the proper imaging, it's time to determine the timing of the radiation. So all these patients we know are going to benefit from radiation. The question is just, do they need surgery beforehand? And the answer is, if they have kind of a single continuous region of compression, they have very good performance status, you can definitely consider surgery followed by radiation. In about 2 weeks or so, we want to allow for proper wound healing. If the patient has a highly radiosensitive tumor, or if they have multiple sites of compression, or if they're just not a very good surgical candidate, then we would probably defer to radiation alone as our preferred treatment. In terms of which exact fractionation scheme we should be using, whether it is in the postoperative or the definitive setting for these patients, I think that all of the trials that came out from Rady's really provided us with good guidance in terms of what to do. We know that long course radiation provides more durable control, but short course radiation and long course radiation provide equivalent symptomatic control. And so 30 gray in 10 fractions should really be considered the standard of care in post-op or definitive setting in patients that have a good performance status and who have a longer life expectancy. If patients have, less of a performance status or less long of a life expectancy, 20 gray in 5 fractions can be a good alternative, and this is often what we see used in the inpatient setting. And then finally, 8 gray in 1 fraction should really be reserved for patients that have a very poor performance status. Now, you may be wondering, what about spine SBRT? Would we ever consider using spine SBRT? And that's a good question. So the SC24 trial, which came out in 2021, published by Dr. Sagal and his team, was a randomized controlled trial comparing 20 gray in 5 fractions, kind of conventional radiation, to 24 gray in 2 fractions, stereotactic body radiation. Now, importantly, the patients in this trial did not have neurologically involved symptomatic spinal cord compression. So they did have spinal mets, no more than 3 consecutive vertebral body segments, but they didn't have symptoms of cord compression. They had to have pretty decent performance status, a low spinal instability score, and no prior radiation or surgery, and then they were randomized to receive either 20 gray in 5 fractions or 24 gray in 2 fractions SBRT. The results actually showed that SBRT with 24 gray in 2 fractions was superior to 20 gray in 5 fractions in terms of complete pain response with no significant increase in toxicity. So we now have a lot of possible treatment options for dealing with metastatic spinal cord compression, and it can be confusing to know what decision to make when you're dealing with a particular patient. To kind of help with this problem and to help guide our decision making, something known as the NOMS framework has come out, and NOMS stands for neurologic, oncologic, mechanical, and systemic. So the table kind of helps you go through the decision framework, and at the end they have a recommendation as to what treatment to pursue based on the patient's factors. So neurologically, is it a low-grade compression, and do they have symptoms of myelopathy? Oncologically, are we dealing with a radiosensitive or a radioresistant tumor? And examples of radioresistant tumors include hepatocellular, renal cell carcinoma, sarcoma, and melanoma. Mechanically, is the patient stable or unstable? And you can use that spinal instability neoplastic score to help assess that. And then finally, systemically, do we think that this patient is going to be able to tolerate surgery? And you will see that in radioresistant tumors, we tend to be more aggressive, pushing more for surgery, as well as stereotactic radiation. And then for the radiosensitive tumors, we tend to be able to get away more with just the conventional radiation. Keep in mind that if a patient has a high-grade radioresistant tumor that's unstable, they're unable to tolerate surgery, the recommendation is stabilization followed by conventional radiation, just because we won't have time to do all the treatment planning for SRS, which is definitely more involved. So I just kind of want to leave this here. If you're ever in doubt as to what to do, this table can be a helpful resource to reference. Obviously, a black and white table is not always going to help us and be the right thing to do for our patients, but it is a good guide to have. And if a flow chart is more appealing to you than a table, then here we have the same information from the NOMS framework laid out as a flow chart. Now we are almost done. We're definitely past the hardest part, but very briefly, I just want to address toxicity and why we need to be so careful when we're dealing with spinal radiation. There are 2 things that you need to know about the spinal cord in terms of toxicity. So number 1, spinal cord is a late responding organ. That means that we worry less about causing acute toxicity during radiation as we may with the skin, and we worry more about causing a late and permanent side effect that manifests months down the road. The other thing that you need to know is that the spinal cord is a serial organ as opposed to a parallel organ. And for serial organs, I think of them as hollow tube-like structures, and if you poke a hole anywhere in the tube, then the entire organ kind of collapses. And if you think about the spinal cord, it makes sense. So it is a tube-like structure, and if you radiate to too high of a dose at one level, then everything from that level down kind of collapses and causes severe side effects for the patient. And when we treat the spinal cord to too high of a dose, what can happen is a side effect known as radiation myelopathy. Radiation myelopathy is a clinical diagnosis. It's a diagnosis of exclusion, and it occurs from damage to an irradiated spinal cord segment. The manifestation can be mild, minor sensory or motor deficits, or it can range to complete paraplegia or quadriplegia and complete loss of autonomic functioning. So if we don't safely treat the spinal cord, we can really cause some horrible side effects for our patients that we definitely do not want to do. The time to development of radiation myelopathy is a period of months, right? Because spinal cord is a late responding tissue. And higher total dose, as well as a higher dose per fraction, are associated with shorter latency time. So that means that stereotactic radiation will manifest, myelopathy will manifest earlier than if you deliver conventional fractionation. To prevent radiation myelopathy, what we try to do is keep the dose to our spinal cord, the point dose to our spinal cord, below a certain threshold. So the Quantec dose constraints are a set of dose constraints that kind of tell us the risk of certain toxicities when we use conventional fractionation, or 2 gray per fraction. These constraints assume no prior radiation, and they assume full circumference radiation. So for the spinal cord, at a point max dose of 50 gray in 2 gray per fraction, the Quantec dose constraints tell us that the probability of grade 2 or higher radiation myelopathy is 0.2%. So in general, if you're asked about what is a safe dose that the spinal cord can tolerate, in 2 gray per fraction, the answer is somewhere between 45 to 50 gray, and based on Quantec constraints, we're accepting a probability of radiation myelopathy of 0.2% or less. We would not accept a probability of radiation myelopathy of 6% with 60 gray or 50% with 69 gray. So we always want to keep that point dose kind of within those Quantec constraints. Remember the number 50 gray in 2 gray per fraction if you're going to remember just one thing from this slide. The high-tech spinal cord dose constraints refer to the dose constraints in the setting of stereotactic radiation. And remember that it's not just about the dose that you're giving, but it's also about the dose per fraction. So it's going to vary greatly. If you're just giving 1 fraction, the point max dose is anywhere from 12 to 14 gray. If you're giving 3 gray per fraction, the point max is anywhere from 20 to 23 gray. If you're ever in doubt, always use an EQD2 calculator and convert it to 2 gray per fraction. And in 2 gray per fraction, we know that we would accept a point dose of 45 to 50 gray. It's super, super important when you're doing radiation plans for the spinal cord to always ask the patient if they've had prior radiation, and also to fuse the prior plans if you have access to them so that you can calculate kind of a planned sum and know in total what the spinal cord is receiving. In the setting of re-irradiation with stereotactic radiotherapy, Dr. Sehgal and his team came out with a paper in 2021 that shows some more flexible dose constraints if you are considering stereotactic radiation in the context of retreatment with radiation. I'm not going to read them all for you now, but they are here as a reference if you ever find yourself in this situation. The last point that we will briefly mention is the radiation technique that we generally utilize when treating the spinal cord. I just want to clarify that this particular slide about radiation technique applies not to stereotactic radiation, but rather for conventional external beam radiation. And remember, this is conventional radiation that we're doing with a palliative goal. And so our radiation technique is going to be fairly simple, either a 2-dimensional or a 3-dimensional plan. If we're treating anything in the thoracic, lumbar, or sacral spine, the safest approach is typically to utilize an APPA beam arrangement, which means one beam coming in anteriorly, so from the anterior to the posterior side of the patient, hence the name AP, and the other beam coming in posterior to anterior, hence the name PA. So an AP and a PA beam kind of shined on either side of the patient. The other option is to use an AP beam and then 2 posterior obliques as shown in the photo on the right-hand side. So we just have one AP beam, but we're kind of splitting the dose that comes from the back into 2 beams that are at oblique angles. That helps us to kind of focus more of the dose towards the posterior side of the patient, which is where the spine is located. So these are just some approaches that you might consider when you're treating anything in the thoracic, lumbar, or sacral spine. If we're treating something higher up in the cervical spine, it depends on where the lesion is located, but typically we would probably favor using opposed laterals. So instead of coming in with an APPA beam, we're now coming in with 2 beams that are directly across from each other, but they're coming in from the lateral side of the patient. The reason for that is that we would not want to shine a beam AP and then enter through the patient's chin or the patient's mouth. So the techniques here are fairly simple. They're very straightforward, but just keep in mind that they can vary depending on where in the spine we're treating. And that is all I have for you in terms of cord compression. If you're going to remember anything from the management section of this talk, I would remember that for cord compression, you always want to start steroids. They may or may not get surgery, and then they will always get radiation. Remember that a longer course of palliative radiation provides more durable control, but a shorter course still provides equivalent symptom control. And stereotactic radiosurgery is an option, but it's typically preferred for radio-resistant tumors or if tumors need to be retreated. Thank you.